That is by Dr. Deven Juneja. Uh, uh, Very good evening, sir. Are you there?
Yeah, good evening.
Okay, so Dr. Deven is the director in the Institute of Critical Care Medicine, Max Super Specialty Hospital, Saket, New Delhi. And he is the editorial board member of three international journals and peer reviewer for more than 50 national and international journals. He has more than 50 publications in peer reviewed journals and more than 40 chapters in the critical care and related textbooks. And he's the co-editor of a textbook on critical care toxicology. And he's the lead author of many ISCCM position papers and guidelines. And he has received the President Citation Award for from Indian Society of Critical Care Medicine 2020 and got the Chairman's Award for Society of Critical Care Medicine Delhi NCR 2017, GEM Award for Max Healthcare 2017, Best Paper Award for Indian Society of Critical Care Medicine at Criticare 2010, and he's the Fellow of the Society of Critical Care Medicine USA, and he's the Fellow of Indian Society of Critical Care Medicine, and he's the Fellow of the American College of Chest Physicians. And he's also the life member of Indian Society of Critical Care Medicine, Indian Society of Anesthesiology, European Society of Intensive Care Medicine, and Society for Critical Care Medicine, SCCM. And he's also the executive committee member of the National Indian Society of Critical Care Medicine and secretary of the Society of Critical Care Medicine, Delhi, Noida. So welcome, Dr. Juneja, and his presentation is on the basic management of mechanical ventilation and oxygen support.
Thank you, Dr. Nikhil.
Over to you. Over to you.
Yeah. Thank you, Dr. Nikhil. I'll be just concentrating on the basics of mechanical ventilation. Many times we know that when the patient comes to us in our ICUs, they require some kind of ventilatory support. The reasons for that is there is a chain of respiratory failure. So when our respiration is started from the brain center and neuromuscular connections are there, followed by the thoracic bellows and the airways and the alveoli. If there is failure in any of these connections, then the patient might go into respiratory failure. And at this point of time, he is going to require some kind of support. So the first support which we generally provide our patients is giving them oxygen. In many patients, this is the only support which is required, but many patients require further respiratory support in the form of mechanical ventilation. So indications, the absolute indication for that would be acute ventilatory failure or arrest. If the patient develops higher CO2 levels associated with respiratory acidosis, then the patient is going to require some kind of ventilatory support. Impending ventilatory failure occurs when a patient can maintain marginally normal blood gases, but only at the expense of increased work of breathing. Then comes severe hypoxemia. If the PO2 is less than 60 on more than 50% FiO2 given through oxygen mask or nasal prongs, or even sometimes we give higher concentrations of mask through non-rebreathing mask. So even if the patient is not supporting well, patient is desaturating on any of these oxygen therapies, then again you should think of putting the patient on mechanical ventilation. Sometimes we have to give prophylactic ventilatory support, and post-operatively, as you must have noticed many times, even after the surgery, we are unable to extubate the patient. So post-operatively, maybe because of oversedation or use of paralytics or for pain control or for immobilization, sometimes in the post-operative period also we have to give prolonged mechanical ventilation. Or if there is decreased systemic or myocardial oxygen consumption, or sometimes to protect the airways. So if the patient's GCS is low, then you would like to maintain the airway by putting in a definitive airway and connecting the patient to mechanical ventilator. So these are the different indications for putting the patient on mechanical ventilation. So when you look at the types of mechanical ventilation, you can further classify that. It can be divided into non-invasive, which is BiPAP or bilevel support, or a high flow nasal cannula. This has really become popular, especially after the COVID pandemic, when most of the patient had type 1 respiratory failure, and now high flow nasal cannulas are available easily all across India. And invasive. But when you look at the different indications of putting the patient on mechanical ventilatory support, be it invasive or non-invasive, they can be simply classified into three broad categories. So my only take-home point, well, my major take-home point rather would be from this presentation would be whenever you are thinking about three indications, you should, whenever you are thinking about mechanical ventilatory support, think about three indications. The first is ventilation. That means the patient is unable to wash out the CO2. As I've already shown, the PCO2 is more than 50, or the patient is requiring pH is less than 7.3. That would be one indication. The second would be hypoxemia, so to give oxygen. And the third is to reduce the work of breathing. So all the other clinical conditions which we have just discussed will broadly fall into any of these three categories. So if any of these three things are present, hypoxemia, hypercapnia, or increased work of breathing, the patient may benefit from use of mechanical ventilatory support, be it invasive or non-invasive. In most of the patients, especially if you have got a monitored bed available with you, the choice of putting the patient on mechanical ventilation, the first choice would be to put the patient on non-invasive mechanical ventilation. But again, as I was telling you, that HFNC has become really popular, and there are certain significant or direct indications for which it has been shown to be really, really useful. You can see the machine over here. I'm sure many of you must have seen a similar apparatus in your ICUs. And this is easy to apply, a portable machine. The basic function of this machine is to give heated, humidified air at high flows. So you can give oxygen at up to the flow rate of 60 liters per minute. So that is quite a high flow. That's why it is called a high flow nasal cannula. And when you're giving oxygen at such high flow rate, it will give you a pressure head. So depending upon, roughly, it is very difficult to estimate how much pressure head you are maintaining when you are giving oxygen at high flows. But roughly for each 10 liters of oxygen flow per minute, it roughly corresponds to 1 centimeter of oxygen. So when you are giving flow rate of around 60, so that roughly correlates to around 6 centimeters of pressure support. So that it will help you in reducing the work of breathing. It will help you in hypoxemic respiratory failure, although it is not clearly indicated. But recently, in the last 2 to 3 years, many papers have come which does show that it might be helpful in patients with hypercapnic respiratory failure too. But other common indications of using HFNC is acute hypoxemic respiratory failure, post-operative patients, especially when the patient has undergone abdominal surgeries. You do not want to put the patient on BiPAP. This nasal cannula, which you can see over here, it is very easy to apply. Patient is more comfortable. Patient can easily take in food. Patient can talk. So the compliance with this machine is much better than our traditional BiPAP machines. So peri-intubation and post-extubation respiratory failure. So these are the common indications for which we are using HFNC, but indication is also coming up in patients with type 2 respiratory failure, COPD and asthma too. So this is the BiPAP machine. Again, I'm sure all of you must have seen a patient being put on a face mask or a nasal mask. And our traditional ventilators, many of the traditional ventilators have the capacity to give a non-invasive ventilation too. But there are smaller, more portable machines also available, which can be applied even in the wards, or patient can take it home also. So again, the indications of putting the patient on BiPAP remain the same as in invasive mechanical ventilation. But obviously, there are certain contraindications in which you should not put the patient on BiPAP. That is cardiac or respiratory arrest, severe respiratory distress, unable to protect the airway or clear secretion, because as you can see, patient is breathing through a mask. If the patient is unable to cough out the secretion, the chances of aspirations are significantly higher. Impaired consciousness, non-cooperative patients, hemodynamic instability or arrhythmias, facial trauma, or upper airway obstruction. So in these patients, you would not like to put the patient on BiPAP or give a trial of BiPAP and directly proceed with putting the patient on invasive mechanical ventilation. So it is very, very important for us to understand when we have put the patient on invasive mechanical ventilation, how does the basic physiology of breathing. So here you can see these are the various phases of breath. Here you need to have a trigger. So trigger means when the ventilator will start the initiate the breath, it is going to require some kind of trigger or some kind of indication that the breath should be initiated. And this is called cycling. From one phase of the respiration, that is the inspiratory phase, the ventilator will move on to the next phase of ventilation, that is called cycling. So from inspiration it will move on to expiration, that is what we term as cycling. Then we need to have certain limits when to limit the inspiration. And the importance of these phases of breath is that you must understand that most of the oxygenation happens during the inspiratory phase. So it is during this phase that the oxygenation is happening, and most of the ventilation, that means removal of CO2, happens during the expiratory phase. So if the problem is associated with oxygenation, it is the inspiratory phase where you need to make the changes. And if the problem is with the CO2 removal, then the expiratory phase where you should concentrate. If you look at the inspiratory phase also, inspiratory phase will have a flow area of at a particular point of time, there will be an inspiratory flow, then there will be a pause time, then it is followed by the expiratory phase. So it is basically the inspiratory pause phase where the maximum oxygenation takes place, because at that point of time, the air has the whatever tidal volume you have set on a ventilator has already gone in, and the alveoli are totally distended and are in close contact with the lung capillaries, and there is easy exchange of oxygen which is happening from the alveoli to the capillaries. This pause time can be set up in different ventilators, but generally it is kept at around 10% of the inspiratory time. So talking about the triggering, this is how we tell the ventilator to initiate the breath. It can be initiated by the patient. When it is initiated by the patient, so the patient has to generate some flows or some pressure by which the ventilator will know that the patient is trying to breathe, and it will help the patient in initiating the breath. Or it can be triggered by the ventilator. So when the patient is in a controlled mode of ventilation, we can simply put it that after every 2 seconds or after every 3 seconds, the ventilator is going to initiate a breath. So that is called ventilator associated initiated breath. So these breaths are generally time dependent at like I was telling, that every 2 to 3 seconds, the ventilator will automatically, irrespective of the patient making any effort, the ventilator is going to deliver a breath. So, and sometimes it is pressure or flow generated. That means the patient has to generate the set flow, or patient has to generate a set negative pressure to initiate the breath, and then the rest of the work will be done by the ventilator. Now we do have some ventilators, advanced ventilators, which can even detect the electrical activity of the diaphragm and initiate the breath accordingly. So here you can see this is where the patient is trying to initiate a breath. So patient takes a deep breath, or patient generates some pressure, some negative pressure. When the ventilator realizes that, yes, patient is trying to generate a breath, the ventilator will deliver the breath over here. And here you can see this is the mechanical ventilator generated breath. So it does not have any negative pressure. So the machine is automatically delivering the breath. So earlier we used to have what we used to call the controlled mechanical ventilation. Now what we have is a assist control. So basically the difference is, in controlled mandatory ventilation, all the breaths were mandatory, or that is generated by the ventilator. So the ventilator did not allow the patient to generate any breaths. And earlier, the clinical practice was also like that we used to sedate or paralyze every patient going on invasive mechanical ventilator. Now we realize that it is less fruitful for us to paralyze all the patients, and we want the patient to be actively involved in the mechanical ventilatory process. And it reducing paralysis also helps in early weaning of the patients. So now we have shifted over from controlled mandatory ventilation to assist control, in which the patients are also allowed to breathe in between. So this is the assist control. Here you can see the ventilator, the patients are generating the breath. There is a negative pressure over here, and the patient is allowed to take a breath. In this ventilatory mode also, we can fix the tidal volume or pressure support, or pressure control rather, which it can be assist control, can be pressure control, or can be volume control. The differences of those we'll be discussing in the next few slides. And the triggers can also be set, and the patient is allowed to breathe in between. If the patient is generating a breath, the mechanical ventilator helps the patient and helps in achieving the fixed tidal volume, or gives the pressure control which has been predetermined by the physician. But if the patient is unable to generate any breath, then the ventilator delivers the backup rate at the predefined time intervals. So as I was telling you, these assist control can be volume control or pressure control. So these are the difference. It is not fair to say that one mode is better than the other. Both the modes have got their own advantages and disadvantages. So whenever you are putting the patient on any of these two modes, you need to know the advantages and the relative disadvantages of each mode. Then your patient should be fine. So like volume control, the set parameter is the tidal volume, and airway pressure is variable. So, and this constant tidal volume is going to get delivered to patient with each respiratory breath, irrespective of the lung dynamics. So even if the lung becomes stiffer, then also the ventilator will keep on delivering the same tidal volume which you have set. But again, the problem with this is that if the ventilator is delivering the same tidal volume, your pressures are going to be very, very high. So if the lungs become stiff, like in ARDS, if lungs become stiffer, then for the same tidal volume, say you have set the tidal volume of 400, the peak pressures, the plateau pressures are going to be much higher. So the pressures are going to be variable with every breath, but ventilator will make sure that the set tidal volume is being delivered with each breath. And there can be some patient ventilator asynchrony, and there is no leak compensation in volume control. As compared to volume control, now in pressure control, it is the pressure control, the pressure you are setting, and tidal volume is variable. So suppose if you have set a pressure control of 20, but your target is tidal volume. So you must understand that you want to deliver a tidal volume of around 4 to 6 ml per kg in a patient with ARDS, or a higher tidal volume of around 6 to 8 ml per kg of predicted body weight in a patient and other patients like asthma and COPD patients. So if with each breath, the tidal volume is going to be different. So when you set the pressure control, you have to stay there and you have to observe how compliant the lung is and how much tidal volume the lung is generating with each breath. So, like if we're talking about asthma and COPD, when the patient comes to you in the initial phases, the patient will have severe bronchospasm. So suppose if you have set up a pressure control of around 20, in the initial phases, it is going to deliver less tidal volume of around 400 to 450. But if once this bronchospasm, you are going to give them a lot of bronchodilators, steroids. So once this bronchospasm settles, on the same pressure control of 20, the patient is going to get a tidal volume of 600 or 650. So you have to determine that what is your goal, and if the patient's condition is changing, you need to change the pressure control accordingly. So you have to be really careful when which mode you are setting, and your patient might require frequent monitoring while you are putting up the patient on invasive mechanical ventilation. So the tidal volume is going to change with the lung dynamics, and flow will also vary according to the patient's demand, and it compensates for leaks. So SIMV is another mode of mechanical ventilator. Again, it was initially intermittent mandatory ventilation. Now it is synchronized mandatory breaths are given and patient is allowed to breathe in between. Like this IMV mode, it was that the patient was delivering getting breaths at frequent intervals. And in SIMV, the ventilator is going to deliver the breaths at predefined intervals, and in between there will be a window when the patient will be allowed to breathe on his own. So here you can see these are the breaths which are generated by the ventilator, and in between there is a window. If the patient is conscious, then the patient can generate his or her own breaths, and the ventilator will allow the patient to take a breath on his own. And these patient generated breaths can be further supported by adding some pressure support to this, and that will also help in reducing the work of breathing, because sometimes what happens is during this window, patient rather than taking one breath can take multiple breaths, and there is a tendency for the patient to get tired out in spite of being on invasive mechanical ventilation. Another setting which we regularly do in our patient is putting the patient on PEEP. Earlier there was a concept of physiological PEEP. Basically, this is a continuous pressure, and we used to believe that that alveoli need to be open throughout. And physiologically, it is going to require around 4 to 5 centimeters of PEEP. But now it is no longer called a physiological PEEP, which we need to give. The basic function of the PEEP is to keep the alveoli open, because every time the alveoli closes and reopens, there is a chance of shear injury. And you want to reduce this shear injury by complete closing of alveoli every time. So you give some amount of PEEP, around 4 to 5, to each and every patient you put on invasive mechanical ventilator. Again, there was a concept of zero PEEP or ZEEP in managing patients with asthma and COPD. The concept was that these patients are already having obstructive airway disease, so their alveoli are already distended. So you do not need to give any PEEP to such patients, because such PEEP can be detrimental or add on to already distended alveoli and increase the risk of barotrauma. So the concept was to give low PEEP or zero PEEP to such patients because their alveoli are already open. So indications for PEEP is, what the PEEP does, it keeps the alveoli open, and it also helps in increasing the mean airway pressure. When you increase the mean airway pressure, that helps in oxygenation. So any condition in which oxygenation is an issue, or lungs are getting very stiff, or there is atelectasis or collapse of alveoli, you would want to increase the PEEP in such patients. So like indications are ARDS, stabilized chest wall, and physiological PEEP to keep the alveoli open throughout the respiratory phases. So these are certain indications. But you also need to be aware that there can be complications associated with high PEEP, especially the risk of pneumothorax, or the risk of hypotension, because the high pressure are being generated, and it can lead to hypotension. So these are few risk factors which you must keep in mind. And contraindications for PEEP is increased intracranial pressure, unilateral pneumonia, bronchopleural fistula, because if you give high PEEP to patients who already have a bronchopleural fistula, it will delay the healing of this bronchopleural fistula and can be detrimental to patient outcomes. Now, when you look at the ventilator, you see that there are 3 different panels. The first is the graphic panels, where whatever changes you make, you look at the graphs and you decide how the patient is doing on a mechanical ventilator. Then there are some fancy knobs or buttons and the ventilator. This is where you make all the settings. And the third section would be the setting of alarms. Again, it is a very, very important component of setting up the ventilator. It is not only the basic modes and FiO2 or respiratory rate which we need to set. It is also important to set the alarms of the ventilator. Otherwise, the alarms will keep on going and the patient might not get ventilated properly. So when you look at these alarms, these are the basic alarms which you need to put. Expired minute ventilation, which is around 10 to 20% above and below the inspired minute ventilation. low pressure alarms, high peak pressure alarm. Your target is to keep the peak pressure less than 35 and plateau pressure less than 30 centimeters of water. But in certain patients like in asthma, COPD, morbid obesity, the pressures might be relatively higher. So you might accept a higher pressure in those patients. Then you need to set the alarm for FiO2, apnea time or backup ventilation. Like I was telling you, the patient is going to deliver. If the patient does not take breath in a defined time period, the ventilator is going to deliver a breath. That is called the backup ventilation. So you need to set the alarms for that. So in different modes, like in volume control mode, you need to check the peak airway pressure, the plateau airway pressure, and low pressure alarms. And during pressure control ventilation, you need to check the expired tidal volume and expired minute volume. So these are specific things which you need to monitor apart from the normal vitals of the patient, saturation, GCS of the patient, and also you have to do the labs, the basic labs like the ABG. So you have to look at all those things. These things are all very, very important while the patient is on any kind of ventilatory support. Another concept which you need to understand is the peak airway and the plateau, peak airway pressure and the plateau pressures. So here, when you look at this ventilatory graphic, obviously the tip of this graph shows the peak airway pressure. As I was telling you, it should be less than 35, and this is the plateau pressure, which should be less than 30 centimeters of water. Normally, the difference between the peak and the plateau airway pressures is around 5 centimeters. So if there are, what do you mean by peak in inspiratory pressure? So when you talk about the peak inspiratory pressure, it is the pressure which is required to overcome the resistance offered by the airways, the lungs, and the chest wall. When you talk about the plateau pressure, it is only the pressure which is required to overcome the resistance offered by the chest wall and the lungs. So any problem which is associated with chest wall or the lungs will increase both peak inspiratory pressure and plateau airway pressure. But if the problem is with the airways, like bronchospasm, secretions, or blood in the airways, or even when the patient is on ventilator, if there is kinking of the tubes, then only the peak pressure will increase, the plateau pressure won't increase. So in conditions of the lung like pneumothorax, massive pleural effusion, morbid obesity, because the compliance of the chest wall or the compliance of the lung is affected, in such conditions, both peak and plateau pressures will be on the higher side. So when only peak pressure increase, the gap between the P peak and the peak plateau pressure is going to increase by more than 5. Again, whenever you put the patient on invasive mechanical ventilation, from the day one itself, you should start thinking that how you are going to wean off the particular patient. Weaning starts from the time you have intubated the patient. But again, there are certain criteria which should be fulfilled or which should be looked at before extubating the patient. Okay, so like the ventilatory workload, if the patient is breathing very rapidly, then you would not like to wean off the patient or extubate the patient. Looking at the oxygen status, cardiovascular function, patient is hemodynamically stable or not, patient is not very having a lot of tachycardia, physiological factors, patient is conscious, patient is able to cough out the secretions or not. But the primary thing is why the reason for which the patient was intubated, whether it has been controlled or corrected or not. Only then you should think about extubating the patient. So weaning criteria, the required PEEP should be around 6 or less than 6. There is a index that is rapid shallow breathing index, that is F by VT. The F is the respiratory rate, VT is the tidal volume in liters. This is a simple formula. You put the patient on pressure support and you see what is the respiratory shallow breathing index, rapid shallow breathing index. If it is less than 105, that means the patient is ready for weaning. And PF ratio should be more than 175, saturation more than 94%, oxygen requirement FiO2 should be around 42, at less than 40 to 50%, and patient should be able to maintain the airway and have adequate cough reflex. Again, when you talk about weaning, there are certain modes which can help you in weaning. You have to give a spontaneous breathing trial. If the one trial should last from 30 minutes to 2 hours, not more than 2 hours is required. Ventilatory mode is the pressure support mode on which you can try, or sometimes you put the patient directly on the TPs. It is not required to put the patient on pressure support first, then TPs trial, and then extubate the patient. You can do either of these measures, and you can put the patient on pressure support ventilation, and you can extubate the patient if the patient is maintaining well on a pressure support of around 6 to 12. Why we talk about some pressure support, why not TPs? Especially in patients with asthma and COPD, there is a lot of airway resistance. And when we are putting a tube, it adds to the airway resistance. And especially for a patient who already has got a lot of airway resistance, this is a significant addition. Try blowing through a tube and breathing through a tube. It will, you will understand that a lot of resistance is there, and you have to generate a significant pressure to overcome this resistance. So this pressure support helps in overcoming the resistance offered by the tube. And if this is generally around, depending upon the size of the tube, the larger the size of the tube, lesser is the resistance. So sometimes if you have put a smaller size tube, or there are a lot of secretions, this resistance can be significant, and it will add to the inspiratory work of breathing. And so that's why to overcome this resistance, you are going to require some kind of pressure support, and that is where pressure support ventilation comes in. But if the patient is able to maintain well on a pressure support, even up to 12, you can think of extubating such a patient. Just a few words about specific patient population. Like the patient with ARDS on one spectrum, there are specific mechanical ventilatory settings which you need to do. Once you put the patient of ARDS on invasive mechanical ventilation, these patients, the problem is oxygenation. So to improve oxygenation, either we give them high FiO2, or we try to keep high mean airway pressures by giving them high PEEP. What do you mean by high PEEP? Generally, as I was telling you, we put a PEEP of around 4 to 6, but in these patients, you might require much higher PEEP, up to 20 you can give. But again, whenever you are giving high PEEP, you have to look at the peak and the plateau pressures, especially the plateau pressures. Your target should be less than 30 centimeters of water, and depending upon your plateau pressure, you have to adjust your PEEP. Low tidal volume, around 4 to 6 ml per kg of tidal volume. So these patients are going to require less tidal volume. And to when you are giving less tidal volume, obviously the minute ventilation is going to get affected. The minute ventilation is going to go low. So to compensate for low tidal volume, you can either increase your respiratory rate, because minute ventilation is a product of respiratory rate and tidal volume. So you can increase your respiratory rate. You can go up to 35. Or the other thing is that you accept higher CO2 levels. So that is what we call permissive hypercapnia. As long as the pH is above 7.2, you can accept a higher PCO2 levels, and that is what we call permissive hypercapnia. Keep a pH of above 7, a higher pH of 7.25 is also acceptable. Plateau pressure, as I was telling you, keep the plateau pressure of less than 30 centimeters. Asthma and COPD on the other end of the spectrum, these patients are going to require low respiratory rate. And ARDS, we are giving them high respiratory rate. In asthma and COPD, we are giving them low tidal volume. We are giving them low respiratory rate. Here, the problem is not oxygenation. Here, the problem is ventilation. That is the CO2 removal. So here, what we do is we keep the respiratory rate on the lower side. Keep the I/E ratio, that is inspiratory to expiratory ratio. Normally it is 1:2. You keep a higher expiratory time, because here the problem is with expiratory flow. So you keep a higher expiratory time so that the CO2 removal can happen rapidly, and keep the expiratory time on the higher side. Keep a I/E ratio of 1.3 or 1.35, and keep the respiratory on the lower side. So again, be very, very cautious. If you are keeping high tidal volumes in these patients, or you are keeping low expiratory time, breath stacking can happen, because expiration is not complete and the next breath starts. and that can lead to auto PEEP. And auto PEEP you can detect on mechanical ventilator by giving an expiratory hold, and you subtract the given PEEP by the PEEP observed on the ventilatory machine settings, and that is the auto PEEP. It can be detrimental. It can lead to sudden fall in blood pressure. Patient will start becoming restless, having tachypnea, tachycardia, and hypotension. If a COPD or asthma patient is developing this, disconnect the ventilator immediately, decompress the chest by gradually pushing the chest in. It can help in immediate restoration of your blood pressure. And you need to take care of bronchospasm. You need to change your ventilatory settings, go to lower respiratory rate, lower tidal volumes, increase the expiratory time, and wash out the carbon dioxide or wash out the trapped air. So to summarize, invasive mechanical ventilation is, or any kind of ventilatory support, is an important adjunct to managing patients with respiratory failure. The broad indications of putting the patient on ventilatory support are three: oxygenation, ventilation, and to reduce the work of breathing. Patient with specific disease may require specific ventilatory strategies. One size does not fit all. So like I have shown you, patients with ARDS have got their own specific needs. And on the other hand, patients with COPD asthma have got their own specific needs. So you have to tailor-made ventilatory strategies as per the patient's requirement. Close monitoring and early weaning may help in reducing complications. Think of weaning of the patient from the time you have intubated the patient. Get them off early, because ventilatory support is also associated with certain complications. And always remember that it is not therapeutic. Ventilator support is not therapeutic. It is just giving you time so that you can take care of the underlying disease. So try to find out what was the underlying reason why this patient required invasive mechanical ventilator, and try to control the cause and get the patient off mechanical ventilator as early as possible. So as on a daily basis, give a sedation break. Think when you look at the patient, just look at the patient and see whether the patient is ready for weaning or not. I'll be happy to take any questions which you might have.
Thank you, Dr. Juneja, for a very simple yet very detailed description of mechanical ventilation. I think kudos to you for your presentation.
Thank you.
I think the major issue in a surgical patient is basically, especially in the cases of abdominal surgeries, is the basal atelectasis, and that leads to leading to hypoxia, and they need a very good analgesia also. So I think that is very important points to when you are dealing with a surgical patient. Over to you, Anand, for any questions or.
Sure, sir. A few questions I had in my mind.
Yeah.
So most of this question is for Devin, sir. Most of the time we receive patients in our ICU, post-surgical patients, maybe major GI surgery, maybe simple GI surgeries, or whatever has been prolonged. They lend to us with mild to moderate hypoxia. What do you think, sir? What could be the cause for this thing? Is ventilator associated pneumonia or anything else like atelectasis could be present in these patients, and what?
Yeah, Dr. Anand, it is a very relevant question. By definition, the patient has to be on ventilator for a prolonged period to develop VAP. Okay, so if the patient is coming directly from the OT, the chances of it developing VAP is very, very less. So it is not that it is VAP. Maybe patient might have aspirated during anesthesia, or might have aspirated earlier on only. And sometimes, because as I had shown you, because of the drugs, or sometimes because of the sedatives and the paralytic agents which have been given during the time of surgery, especially during abdominal surgery, many times you insufflate the stomach with gases. So that can also add to atelectasis. So all those things can happen, and which can help in perioperative time. Many patients are going to require ventilatory support. So for such patients, we earlier used to use BiPAP, because obviously it was non-invasive. You do not want to keep the patient, you do not want to re-intubate the patient. You have just extubated the patient. But now with the BiPAP, The problem is like after GI surgery, so your sutures can get disturbed or disrupted. And there can be a lot of gas insufflation because you are putting a mask which the air is
Aerophagy.
high flow. It is going through the mouth, it is going through the nose. So a lot of aerophagia is also there. So you are a bit skeptical. So now obviously we have started using HFNC. It is now easily available with us. So put the patient on HFNC. It will give you a pressure head. It will reduce the work of breathing. If there is some atelectasis, it will help in opening up those alveoli by giving a pressure head. And because of the high flow of the oxygen, is going to resolve your hypoxemia also. Many patients are going to require in the perioperative period, especially in the first 4 to 6 hours, they are going to require some kind of ventilatory support. So it is very, very normal. So the reasons are many, as I've already enumerated.
Sir, another question from a colleague is ZEEP is still in use in obstructive airway disease. Should we use it or not?
That's why. So minimum, like I was telling you earlier, this was a very fancy term to ask in our MCQs also that in which patients you can apply ZEEP. So obviously it is a fancy term and we tend to use such fancy terms. But again, minimum PEEP which is required, you should give that. Normally in our day-to-day clinical practice, we do give a PEEP of around 4 to 5 even in patients of asthma and COPD also. But whatever minimum PEEP is required, you should give that for each and every patient. It is not true only for asthma or COPD. Even in ARDS patient, we try to come down on PEEP as soon as possible. And whatever the patient is tolerating, we try to come down on PEEP as much as possible. So zero PEEP we generally do not apply. But yes, whatever minimum PEEP around 4 to 6, that is the general practice.
Thank you, sir. So, sir, as you said, that atelectasis can be a problem in the post-operative period for hypoxia. I think the physiotherapy and good rehabilitation could be of good use in managing those conditions. So with this, I would like to invite our next speaker for this evening,